Thanks. Hi, good evening, everybody. This is Dr. Roshni from the medical team of USV, and a very warm welcome to our speakers and an expert panel from CME India Group, brought to you by Dr. N.K. Singh sir in collaboration with USV. Today's topic of discussion would be what physicians must know about HIV in 2024. So, without taking much time, it's my privilege to welcome the person behind the CME India, Dr. N.K. Singh sir. He's the director, diabetes. One slide back, please. He is the director, Diabetes and Heart Research Center, Dhanbad, chairman RSSGI Jharkhand, ex-governing body member from National API, having numerous publications to his credit, and admin and founder of CM India WhatsApp group. Also, researcher and an editor for various journals. I welcome you, sir, on behalf of Team USV, and over to you for the further proceedings.
Yeah, thank you. Thank you very much. Good evening to you, all our audience and all our panelists. Today, I have really great pleasure with that we have got a very eminent speaker to talk on what we should know. All physicians should know about the HIV/AIDS in 2024 and in the next coming year. Uh, I always think that HIV/AIDS is the such a subject which should be known to each and every person dealing with the medical practice, whatever may be the specialty, cardiology or diabetology or anything, because every day we are dealing with such cases and we are missing it. And there has been lots of changes also in the how to test, how to proceed for referral, and how what suppose post exposure prophylaxis and many other things have something. I think a sea change has taken place. For that, I think that Akash Singh is there. So you are well aware that Akash Singh is the part of CME India. He is now a diabetologist basically at West at the Barodara, uh, involved in the many research papers, many research projects. So Dr. Akash, formally welcome our speaker, and you also introduce our two other panelists, Dipanjan and Dr. Deepit Singh, and then our speaker, and then we will proceed. So Akash, hand over to you.
Thank you, Miss. Can I have the CV PPTs of the speakers?
Yeah, first you give the panelist like Dr. DP Singh. Yeah. Yeah, next. Go for next, yeah.
I welcome Dr. Professor DP Singh, who is moderating this session. He is a very versatile and very um, um, upcoming and is a former professor at the Department of Respiratory Medicine, Bhagalpur, member of API, PRF 2024 to 2027 governing body, member of National API, chairman of IMA Academy, past president of CSI Bihar. And he is adorned with a lot of fellowships of the American, the British, and the Indian physician organizations. And he's author and editor of 6 ICP monographs. And he is very pragmatic and very young for his age and involved in lot of academic activities. The next CV. Uh, I also welcome Dr. Dipanjan Bandyopadhyay, who is a senior consultant, Department of Medicine, Thalamus Institute of Medical Sciences, Siliguri, the senior consultant in the Department of Medicine with over 220 years of experience, specialization in general medicine, currently affiliated to the Thalamus Institute of Medical Sciences, known as the best hospital in Siliguri. He also holds a lot of eminent fellowships of national and international organizations, and we are glad that he's moderating this session. I will like to have the CV of Dr. B.B. Rewari. Dr. B.B. Rewari is personally known to me. I've met him several times. He's a visiting professor, epidemiology and public health specialist, Institute of Liver and Biliary Sciences, Delhi, former regional advisor, hepatitis, HIV, sexually transmitted infections, WHO Regional Office for Southeast Asia, is an honorary clinical professor, Global Health, University of Washington, USA, is a member of Global Validation Advisory Committee, WHO HQ Geneva, is 90 articles and chapters, co-editor of book HIV/AIDS Clinical Perspective, number of orations from API, IMA, IICM, DMA, Best Teacher Award by Delhi Medical Association, Best Physician Award by Vice President of India. So he's a very hugely adorned physician and a very, very a major expert in this field. And we welcome him to talk on this subject of HIV today. Dr. Rewari, please.
I think Akash, Dr. Dipanjan has joined. Welcome, Dipanjan. We just read your CV. So
Uh,
Dr. Rewari will be
uh,
starting, and then you will be moderating the case, the whole thing. Yeah, so that we will now invite Dr. Rewari to start.
Thank you. Thank you, the organizers, particularly Dr. N.K. Singh, for giving me this opportunity. And I see Dr. N.K. Singh has also been involved in HIV care long back, around 20 years back, when we used to work together. Also, a number of presentations on opportunistic infections, mother-to-child transmission, and many other things. Dipanjan, we know all, has been involved in HIV for many years. Is a close friend. And Dr. D.P. Singh, Akash, they are all good friends. So I'm in a very familiar kind of audience. And thank you for this opportunity. So my topic is what physicians must know about HIV/AIDS in 2024. So when we talk of HIV/AIDS, some of the key milestones in HIV epidemic, we have now completed almost 43 years of HIV, and it has passed through three key phases. The initial phase was a devastation phase in early 80s, when we were hardly aware about what is the virus, how it spreads, what will happen, millions of people will die, and there was a denial that people were saying that we are not going to get HIV, we are religious, pious people, particularly in India. But then came the phase of discovery and action, when new and new drugs were discovered in 90s and 95 to 2005. And then just in 40 years, we are talking of ending AIDS by 2030. So there has been significant advances in HIV, and it is important to capture some of these and update the participants about what has been new and what is the current guideline. So if we see, 1981 was the first cases, when first AIDS cases were reported on 5th of June 1981 from California. And every year, if you see the line, there has been a great discovery. Within 2 years, virus was discovered. Within 2 years, diagnostic test became. 2 years later, first drug became available, AZT, for treating HIV. And then 1996 is called the watershed in the history, because in 1996, triple drug therapy became available, what was earlier called highly active antiretroviral therapy and is now just called ART. And then genotypic resistance test became available. And 2016, we had new hopes, newer drugs, and 25 ARVs become available, which were more tolerable and once daily. And long-acting drugs have now recently come in, which can be once injection, once in 2 months, 3 months, or even once in 6 months. So before I go to the technical guideline, I would just like to give you a snapshot of what is the situation in India. Globally, we have 39 million people estimated to be living with HIV, 2.47 million in India, that is 24 lakhs. Significant decline in new infections, both globally and in India. Almost out of 39 million people, 30 million are getting treatment, and India, out of 24 lakhs, 17 lakhs are getting treatment for antiretroviral therapy. AIDS death has declined significantly by almost 60% over last 10 years, and our prevalence is quite low. But because of our large population, the numbers translate from a low prevalence. But I would also like to highlight, particularly to physicians, they may not be interested in data, but you get all kind of clients in your practice. The prevalence of HIV is 0.2% in general population, but if you see among drug users, it is 9%. In transgenders, it is 8%, 3% in MSM, 1.9% in prison inmates, 1.8% in sex workers. So prevalence in these groups, which are called high-risk groups or which are called key population, is much higher than general population. So it becomes very important when you talk to a person who has come to you for first time, you just ask him about the risk behavior also. So when we talk of management of HIV, besides physician, we need to collaborate with lab experts, with nutritionists, with psychologist, and very importantly with the caregiver of the patient. That is the most important component, because the adherence of the person is going to depend on the caregiver, particularly for children. So management of HIV is a multidisciplinary approach. It is also important for physician to have early suspicion, that you suspect them early, diagnose them and link them to care. Why I'm saying so? Because it has been seen that almost 20 to 30% of people who are diagnosed with HIV, with advanced HIV, particularly have visited some physician. Dr. N.K. Singh was saying this in the beginning. They have visited some physician, HIV was not suspected and it was missed, and then later on they presented with a kind of advanced disease, and CD4 count was very low and mortality is high. Our four pillars of management are basically, we need to have general management. In general management, we need to look into the history of the patient. We need to advise him on the nutrition. We need to advise him on safe sex, use of condom, yoga, exercise, healthy living, taking care of stress. That is why it is important them to link to a counselor or to a caregiver or to a psychologist. Treatment of opportunistic infection, diagnosis and treatment, chemoprophylaxis of opportunistic infection, and then antiretroviral treatment. It is very impossible to cover all these four topics in one lecture, particularly treatment of opportunistic infection. That itself is 1 hour talk. And this is a physician's forum. So most of us know that tuberculosis treatment we have been treating. We know the treatment for, I'll go through some of the key uh, opportunistic infection which are not commonly seen in immunocompetent person, like pneumocystis, cerevisiae pneumonia, cryptococcal infection. So I will briefly touch upon them, but not in details. I'll be focusing my talk on antiretroviral treatment. And as a physician, when a person comes to you with a HIV positive report, I think you need to first see whether this report is correct or not. When I say why, because if any person is labeled as HIV positive, it is a big shock, because it's not a curable infection. Besides that, there is a lot of stigma associated with it. People are discriminated. People are turned out of their houses, particularly females. Children are denied admission in the school. And if they know the status, people don't like to sit with them. So it is very important that we are sure that there is HIV infection is a confirmed diagnosis. So we need to be 100% sure. And when I say 100% sure, just look at the report. The report which has come to you from a private lab, we have to really look whether this has been done using 3 tests. When I say 3 tests, we mean that on one blood sample, that sample has been tested with 3 tests and with different antigens. So when we do a test with one test, it is positive. We do the same sample is tested with second kit, and that is positive, then it is tested again with the third kit. If all 3 are positive, then it is reported as HIV positive. If first is positive but second is negative, then we repeat first test. I don't want to get into details of this because these are lab issues, but what you have to understand, see the report whether they have used 3 different kits before giving a result. Because if one test is done, it may be 100% sensitive, but specificity may be 99.9%. So there are 0.1% chance that this may be a false positive. Because a sensitive test will pick up all positives, it will also pick up some false positives. In all government integrated counseling and testing centers, they do give a positive report after doing 3 tests. But in some private labs, it is not so. So very important that you ensure that it has been done with a 3 test. So once a person is with you, we have to look into opportunistic infection, look into what are the various comorbid condition, manage them, simultaneously evaluate them for antiretroviral therapy. We know that antiretroviral therapy cannot cure HIV infection as of now, but why do we want to treat the person when it cannot cure? We know we cannot cure diabetes. We know we cannot cure hypertension. We cannot cure bronchial asthma in most cases. We just manage them with drugs. Similarly, we can manage HIV infection with a very simple antiretroviral therapy. And most of the patient on antiretroviral therapy will be just taking one tablet at bedtime once a day, which is much, much simpler than taking 2 times or 3 times antidiabetic drugs, taking insulin, taking 1 or 2 antihypertensive, taking some ecosprin, some atorvastatin. So antiretroviral therapy as such is very simple with a single pill. The only thing is the adherence has to be 100% so that there is no development of resistance. Because unlike diabetes or hypertension, you can start and stop treatment. It will get uncontrolled, but it will get controlled again with the same drug, which is not the case with HIV because virus will develop resistance if the treatment is suboptimal. So our aim of treating is basically that we reduce the viral load significantly. Not only reduce it to maximum, and that reduction is sustained. So with these drugs, we are able to prevent the virus replication. And once the virus replication is prevented, the viral load is suppressed, the CD4 count goes up, there is immune reconstitution, and then immune reconstitution is there. Person's opportunistic infections are reduced, his quality of life is improved, his hospitalizations go down, and survival is also improved. So our aim is viral reduction, suppression of the virus. And for that, it is important that we use these drugs in a rational sequencing. Which are the drugs to be used first, which are the drugs to be used in second, and then what if the person fails. So I'll go through these in detail. What are the first line drugs? What are the second line drugs? What are the third line drugs? And by reducing the viral load, we are also reducing the transmission. U equal to U is one thing which is called undetectable, untransmittable. If your viral load is undetectable, the virus cannot be transmitted. So that is a very important message we want to tell to the patient, that if you want to protect your spouse, you want to protect your wife, you want to protect your children, you have to be virally suppressed and undetectable so that you're not able to transmit the virus. So when we decide that the person has got HIV infection, we want to start treatment. Most important thing is that it is a simple therapy, but patient has to understand that it has to be 100% adherence all through his life. You will agree with me that if you have to take metrogyl yourself 3 times a day or antibiotic even twice a day, simple cotrimoxazole twice a day for 5 days, we tend to forget in between. I don't think many people complete a course. As soon as they become all right, there is a tendency to forget. Not when you are sick, you will be taking, but when you are okay, then you will be missing out on your. So person has to be adequately prepared. You have to develop a rapport with the patient, educate him on the treatment. In addition to treatment, you have to also educate him on the positive living, yoga, exercise, nutrition, psychological assessment, and develop an individual treatment plan. So when you evaluate a person, particularly when you are taking history, you have to rule out tuberculosis. Tuberculosis is the commonest opportunistic infection, and almost 50 to 60% of the PLHIV will have tuberculosis sometime in their lifetime. There are 15 to 21 times more likely to have tuberculosis than general population. So on every visit, you have to do what we call as 4S screening. 4S screening is basically for tuberculosis. So you have to ask fever, weight loss, cough, night sweats, any duration, not 2 weeks, like we say in general population, fever of more than 2 weeks. No, fever of any duration, weight loss more than 10%, cough, night sweats, any one of them, you have to suspect TB and rule out TB. But if none of them is present, then you can safely rule out tuberculosis with a very high negative predictive value and provide them TB preventive therapy to prevent reactivation of TB. We'll go to that little details in later on. You also look into any persistent symptom, headache, poor concentration, seizure. This could be indicative of some cryptococcal infection, toxoplasmosis. You have to look into diabetes, hypertension, contraceptives, because these will actually alter your treatment. Look into risk behavior, look into family history, whether they have taken treatment in the past and stopped in between. They might be resistant if they have taken the treatment. And then you have to look into mouth, look for the fungal infection, painful swelling, stomach. So these are some of the things basically you have to see in the history and clinical evaluation. General examination, I will not go into details. A very thorough systemic examination has to be done on all the system, and especially don't forget to look for other sexually transmitted infection, which patient may not tell you outright. Now, earlier there used to be a long list of investigation that needs to be done. No, you don't need these large number of investigation for every system. So what you require is basically are these very few investigation. You need a hemoglobin. You have to see whether it's more than 9 or less than 9 to see what treatment to give. Fasting blood sugar, renal function, liver function, CD4 count, not required for starting treatment, but required for classifying patient to advanced disease, X-ray chest, for women, pap smear, or even a visual inspection with the acetic acid VIA. Other symptoms will be basically depending on the symptom and signs to rule out opportunistic infection. You can do a lipid profile if required. You must do a surface antigen for hepatitis B, anti-HCV antibody. Those with CD4 count less than 100 do a fundus examination, because if we have cytomegalovirus retinitis and the person, its progresses very fast and person can become blind. Then you do a pap smear, and in endemic areas you need to do a RK39 strip test to confirm or rule out. But if you focus on this line, non-availability, non-feasibility, however, tests should not delay initiation of ART, because they are not going to determine your regimen as of now. These are required for monitoring the treatment. So when do we start ART? They were earlier that we used to start when we started ART in 2004. We'll start when CD4 count is less than 200. Then came 350, 500, then treat everyone. Now the guideline is that you treat everyone with HIV infection. And why this has changed? This has changed with different randomized control trials over the years, and the evidence from these studies showed that starting ART early is benefit. You know, in 2005 and 10, there were number of pills to be taken. Nevirapine, efavirenz, these were toxic drugs. Zidovudine will reduce anemia. There were multiple regimens. So the cutoff used to be either less than 200 or less than 350. But if you see these two studies, Temprano study and START studies, they provided evidence that if you start ART even when CD4 count is high, there will be 44% less deaths and 53% decline in TB infection. So these studies provided evidence that you start ART for everyone, irrespective of CD4 count or clinical stage, for adult, children, adolescent, anyone. So we don't need to have CD4 count for starting antiretroviral therapy or clinical staging. Now, what drugs to use? This is a typical diagram, which basically this is a CD4 cell. Why I am showing this in detail? Because this will tell you where the drugs act and why do you use multiple drugs. So this is CD4 cell. This is a virus which basically attaches to the CD4 cell at the receptors particularly, and this attachment is facilitated by CXCR5 and CCRS receptors. With these, the virus is able to bind to the CD4 cell. It sheds its RNA. It's a RNA virus that is called retrovirus. And then this is changed to DNA by enzyme called reverse transcriptase. And then this DNA is integrated into the nucleus of the host by enzyme called integrase. Process is called integration. And then this transcripts into viral RNAs, which then bud out of the virus through enzyme called protease, which actually cuts these chains of RNA into small. So what you have seen, basically there is an enzyme involved here, reverse transcriptase, which changes RNA to DNA. There is an enzyme called integrase, which basically integrates the virus RNA into the host RNA. And then there is an enzyme called protease. So drugs are basically acting on these enzymes. These enzymes basically are blocked by viruses. So drugs which block reverse transcriptase are called reverse transcriptase inhibitors. Drugs which block integrase enzyme are called integrase inhibitors. Drugs which block the protease enzyme are called protease inhibitors. So the drugs are basically only blocking the replication of the virus. You see, if any of these is absent, the virus will mutate and start replicating. So it is important that we block this replication of the virus at multiple stages. So that is the key point in understanding antiretroviral therapy, why we use 3 drugs and why virus cannot be killed. If we withdraw these drugs, immediately virus will start replicating and person will again have high viral load. Because these drugs are only blocking the enzymes, they are not killing the virus which have been established, which is persistent in basically reservoirs, like reservoirs are T cells, macrophages, and these are available in tissue compartments like gut, brain, spleen, lymphoid tissue. So they always persist in these sites. So you're not able to eradicate these viruses from these sites. So if you stop the drugs, the virus will come out and start replicating again. So standard of care is using 3-drug combination. This is just to show very old slide, just to show you that if you give single drug, percentage of patient progressing to HIV basically will be just 25 to 30%. They will progress to HIV very soon in few weeks. Even with dual therapy, they will progress to this. But if you're using triple drug therapy, the virus will continue to be suppressed over weeks and months and years. So what are the 3 drugs? 3 drugs we use from different groups of drugs. Like I told you, there are drugs which are basically called integrase inhibitors, reverse transcriptase inhibitors, integrase inhibitors, and protease inhibitors. So these drugs basically we use combination from 2 different classes, not from one class. And preferred is we use 2 nucleoside reverse transcriptase inhibitors and 1 integrase inhibitor. So this is basically the basis of antiretroviral therapy, and the common regimen that we are using most commonly is tenofovir, which is a nucleotide reverse transcriptase inhibitor, lamivudine nucleoside reverse transcriptase inhibitor, and dolutegravir integrase inhibitor. All these drugs basically come in a single pill. They are available in the single pill. In our ART center, we call this as TLD. So TLD is the preferred regimen which is to be given to everyone who is HIV infected, irrespective of CD4 count or viral load, and 1 tablet daily to be given. Now, many people say that why we should not do a baseline viral load to see what is the amount of virus in the body. No, it's not required, because these drugs will act and take time to suppress the virus, and only after that you will know that the virus is suppressed or not. If the viral load is 1 lakh or 2 lakh or 5 lakh or 10 lakh, the drug remains the same. So there is no point in getting a baseline viral load, because many of the practitioners get a viral load done immediately whenever they see HIV positive report, CD4 count कराओ, viral load कराओ, और एक लंबी list investigation की होती है. That is not required. Viral load at baseline is not at all required. It costs 5,000 to 6,000 unnecessary expense to the patient. So TLD is the regimen. Now I'll not go into details, but I'll tell you why dolutegravir came in. Because earlier, if you have been prescribing in your practice or in your medical college and all, it used to be efavirenz. The drug of choice used to be tenofovir, lamivudine, efavirenz. Efavirenz had got significant side effects over time: suicidal ideations, nightmares, depressive tendencies. And efavirenz was a weak drug in terms of potential for drug resistance, because even 1 or 2 mutations in the virus will render the drug ineffective. So dolutegravir has been studied in different studies, which are called single study, flamingo study, spring study, sailing study, where it has been compared with various other drugs. And all these results from of almost more than 3,000 patients showed that dolutegravir suppresses viral very quickly. Within 4 weeks, it can suppress the virus compared to 12 weeks with the efavirenz. So that makes it a very robust drug. The toxicities are very few. Less than 2% patient discontinued the drug due to side effects, compared to 13% which was with efavirenz. Neuropsychiatric effects are 5% compared to 35% with efavirenz. So these are the studies which showed that the drug has got minimal toxicity, minimal resistance. There are no known treatment emergence resistance, minimal drug-drug interaction, and this is also effective against HIV too. Almost 4 to 5% of the people with HIV may be having HIV too, and earlier drug nevirapine, efavirenz were not effective against HIV too. So you will see that dolutegravir offers a lot of benefits: potency, very little chance of getting resistance, very few side effects, and effective against HIV too. So dolutegravir became the preferred regimen across the globe, and this is the preferred regimen everywhere, including India. Now, whenever a physician basically starts a drug, he has to really look into what are the drug-drug interaction, because patient may be taking many other drugs simultaneously with him. So what are the other drug-drug interactions that we really need to look into it? Very few. I've highlighted three common ones. These are the commonly used drugs. हर पेशेंट कहीं ना कहीं एंटासिड लेता है, मल्टीविटामिन लेता है, सप्लीमेंट लेता है, केमिस्ट के पास जाता है, मुझे वीकनेस हो रही है, वो उठा के उसको कोई ना कोई मल्टीविटामिन दे देगा, एसिडिटी हो रही है सो डाइजिन दे देगा. एंड ऑल दीज हैव गॉट एल्युमिनियम, कैल्शियम, आयरन, मैग्नीशियम, जिंक. जिस भी प्रोडक्ट में ये है, they will reduce the bioavailability of dolutegravir. So you have to administer dolutegravir at least 2 hours before or at least 6 hours after such formulations. तो हम इसलिए पेशेंट को कहते हैं कि बेटर है तुम डोलोटेग्राविर रात को ही खाओ, अनलेस ही इज ऑन नाइट ड्यूटी एंड इट कम्स इन द मॉर्निंग एंड काइंड ऑफ थिंग. सो डोलोटेग्राविर खाने के 2 घंटे बाद खाओ, तो आपका इंटरेक्शन 6 घंटे के बाद, तो ये गैप रखना बहुत ज़रूरी है. सो डोलोटेग्राविर टू बी टेकन एटलीस्ट 2 hours बिफोर और 6 hours आफ्टर सच फॉर्मुलेशन जिनमें ये है. रिफेम्पिसिन वी नो इज ए पोटेंट इनिबिटर, साइटोक्रोम P450, तो ये डोलोटेग्राविर की अवेलेबिलिटी कम करता है. अल्टरनेटिव टू यूज रिफाब्यूटिन, बट रिफाब्यूटिन अवेलेबल नहीं है इंडिया में अब, पहले अवेलेबल थी. तो जब भी हम रिफेम्पिसिन दे रहे हैं साथ में एटीटी में, तो डोलोटेग्राविर की डोज डबल करनी ज़रूरी है. और डबल कैसे करेंगे? क्योंकि हम फिक्स डोज कॉम्बिनेशन यूज़ कर रहे हैं टीएलडी का, उसमें 50 मिलीग्राम डोलोटेग्राविर है, तो वो हम डोलोटेग्राविर टीएलडी रात को देंगे और एक डोलोटेग्राविर की सिंगल टेबलेट मॉर्निंग में देंगे, जिससे डोलोटेग्राविर डबल होगी. टेनोफोविर लेमिउडिन को डबल करने की ज़रूरत नहीं है. सो 1 TLD एट नाइट एंड 1 DTG 50 मिलीग्राम इन द मॉर्निंग, एज लॉन्ग एज द पर्सन इज ऑन रिफेम्पिसिन. मेटफॉर्मिन, डॉक्टर एनके सिंह को बहुत जगह सुना है 10% लोगों को डायबिटीज़ है, तो वो 10% PLHIV को भी डायबिटीज़ होगी, वो भी मेटफॉर्मिन ले रहे होंगे, ड्रग ऑफ चॉइस. तो हम जानते हैं कि मेटफॉर्मिन की मैक्सिमम डोज 2 ग्राम है, बट मेटफॉर्मिन का बायोअवेलेबिलिटी डोलोटेग्राविर बढ़ा देता है. तो हमें मेटफॉर्मिन की डोज 1 ग्राम तक रिस्ट्रिक्ट करनी है जब हम DTG के साथ यूज़ कर रहे हैं. अदर ड्रग्स आर नॉट कॉमनली यूज, हेमोडाकिन, कार्बामेज़ापिन, फेनेटोइन, तो उनके साथ ड्रग ड्रग इंटरेक्शन है और हमें मॉडिफाई करनी पड़ेगी. बट ये 3 बहुत इंपॉर्टेंट चीज़ें जो फिजिशियंस को याद रखनी है. साइड इफ़ेक्ट्स, बहुत कम साइड इफ़ेक्ट्स हैं. कुछ लोग कहते हैं नींद नहीं आती, हेडेक होता है, डिजीनेस होती है, 2 से 3%, 4% पेशेंट को होता है, बट इट सेटल्स डाउन ऑन इट्स ओन इन 2 to 3 weeks, मैक्सिमम इन 2 to 3 months. DTG के साथ वेट गेन होता है. हम वेट गेन को साइड इफेक्ट बोल रहे हैं, क्यों? हमारे यहाँ ओबेसिटी की प्रॉब्लम है, हमारे यहाँ कार्डियक डिजीज एक डिकेड अर्लियर होती हैं कंपेयर टू वेस्टर्न कंट्रीज, हाइपरटेंशन की प्रॉब्लम है. तो इनिशियली तो PLHIV वो वेट गेन बहुत अच्छा लगता है, क्योंकि ज़्यादातर PLHIV वेट कम होता है न्यूट्रिशन की वजह से और रीजंस की वजह से, अपॉर्चुनिस्टिक इन्फेक्शन की वजह से. तो जब उनको वेट गेन होता है तो उनको अच्छा लगता है, बट एक लिमिट के बाद फिर वो वेट गेन भी प्रॉब्लम बन जाता है. तो देर आर स्टडीज विच शोज दैट देर कुड बी ए वेट गेन ऑफ ऑलमोस्ट 3 to 5 kgs व्हेन वी आर यूजिंग टेनोफोविर, लेमिवुडिन, डोलोटेग्राविर. और कुछ लोग जब टैफ यूज़ करते हैं, जो कि इंडिया में नहीं यूज़ कर रहे हैं हम, उसमें 6 से 8 किलो भी हो जाता है. सो जब भी डोलोटेग्राविर स्टार्ट करेंगे, पेशेंट को न्यूट्रिशनल काउंसलिंग, डाइट काउंसलिंग, हेल्दी डाइट, अवॉइडेंस ऑफ टोबैको, एक्सरसाइज, ये हाईलाइट करना बहुत ज़रूरी है, सो दैट ही डजंट गेन अनयूजुअल गेन ऑफ द वेट. अब जब डोलोटेग्राविर नई नई आई थी, तो बेसिकली एक कंसर्न आया था लोगों का कि कुछ लोगों को न्यूरल ट्यूब डिफेक्ट हुआ है इससे. तो ये हुआ कि अब हम प्रेग्नेंट वुमेन को दे सकते हैं या नहीं दे सकते हैं. तो उसमें स्टैंड ये था कि न्यूरल ट्यूब डिफेक्ट जो है, हम जानते हैं कि न्यूरल ट्यूब क्लोजेस बाई 12 weeks. तो 12 weeks में न्यूरल ट्यूब क्लोज हो जाती है, और बहुत सी जो लेडीज़ हैं उनको प्रेगनेंसी का पता ही 12 weeks के बाद लगता है, 3 months के बाद पता लगता है. 4 weeks, सॉरी, नॉट 12 weeks, 4 weeks में क्लोज हो जाती है, 28 days में. और 28 डेज बाद ही पता लगता है प्रेगनेंसी का। सो इसलिए उसमें कोई रिस्क नहीं है। बट जो लोग आपके पास प्रेगनेंसी से आए हैं, डायग्नोज हुए हैं, उनको दे सकते हैं। अब कंसर्न ये है कि जो डोलोटाग्राविर पे हैं वो प्रेग्नेंट हो गई, तो उस 28 डेज में न्यूरल ट्यूब डिफेक्ट का चांस हो सकता है। बट ओवर द years वी हैव सीन दैट दिस हैज रिड्यूस फ्रॉम 0.3% चांस टू 0.08%. So dolutegravir has got slight risk of neural tube defect if woman is on DTG and becomes pregnant, but इसका benefit in preventing mother to child transmission is very high because this will suppress the viral load in 4 weeks itself and वो बेबी को वायरस पास ऑन नहीं होगा। तो हम वुमेन की काउंसलिंग करते हैं कि डीटीजी बेस्ड रेजिमेंट लो। पर अगर कोई वुमेन आपके काउंसलिंग के बावजूद भी कहती है नहीं मैं रिस्क नहीं लेना चाहती, तो उसको फिर हम एफाविराज भेज देते हैं। सो जब हम टेनोफोविर यूज़ कर रहे हैं तो एज ए फिजिशियन आप टेनोफोविर और जगह भी यूज़ करते हैं। तो जिनकी भी एज मोर देन 40, अंडरलाइंग रीनल डिजीज है, सीवियर डायबिटीज, सीवियर हाइपरटेंशन, उनमें हमें बेसिकली क्रिएटिनिन क्लियरेंस मॉनिटर करनी चाहिए। और क्रिएटिनिन क्लियरेंस लेस देन 50 हो तो टेनोफोविर को अवॉइड करना चाहिए। क्रिएटिनिन क्लियरेंस करने के लिए फार्मूला है गॉकफ्रिड गोल्ड फार्मूला, ये हम लोगों को मालूम है, बट जस्ट फॉर कंप्लीशन आई हैव गिवन दिस हियर। अब अगर हमारा क्रिएटिनिन क्लियरेंस लेस देन 50 है, 30 to 50 है, तो हमें बेसिकली टेनोफोविर की डोज हमें कम करनी पड़ेगी वंस इन 2 days 48 आवर्स। लेम्बुडिन की डोज भी कम करनी पड़ेगी। बट मेरा सजेशन ये है कि इन सब केसेस में आप एक एक्सपर्ट को रेफर करें तो बेटर है, जो HIV एक्सपर्ट, ART एक्सपर्ट है, सो दैट एडिक्वेट डोजेस कैन बी गिवन। क्योंकि प्राइवेट सेटअप में आपको ये अलग अलग टेनोफोविर मिलेगी भी नहीं। मार्केट में टेनोफोविर, लेम्बुडिन, डल्ट्रागोविर कॉम्बिनेशन मिलेगा। आप कहेंगे मुझे टेनोफोविर दे दो, शायद मिल जाए, क्योंकि टेनोफोविर बेसिकली यूज़ होती है हमारे हेपेटाइटिस में भी यूज़ होती है। बट लेम्बुडिन अब यूज़ नहीं होती है हेपेटाइटिस में, तो आपको अलग से लेम्बुडिन नहीं मिलेगी। तो सच केसेस शुड बी रेफर टू एन एक्सपर्ट। सिमिलरली हेपेटिक डिकम्पोजिशन में हमें ज़्यादा डोज अल्टरेशन करने की ज़रूरत नहीं है। ओके, अगेन टू एम्फिसाइज, अब हमें पता है कि हमें सबको ART देना है इर्रिस्पेक्टिव ऑफ CD4 काउंट। हमें पता है हमें क्या देना है, हमें TLD देना है। हमें पता है TLD क्यों देना है। हमें ये भी पता है कि TLD के साथ हमें एंटासिड मल्टीविटामिन नहीं देने हैं। हमने ये भी समझ लिया कि हमें TLD में अगर रिफेम्पिसिन दे रहे हैं तो उसकी डोज बढ़ानी है DTG की। हमने ये भी समझ लिया कि मेटफॉर्मिन अगर हम यूज़ कर रहे हैं तो उसकी मैक्सिमम डोज 1 ग्राम देनी है। बट ये सफिशेंट नहीं है। फिजिशियंस के लिए ये दवाई के बारे में जानना ज़रूरी है, बट ये सबसे ज़्यादा इम्पोर्टेंट ज़रूरी बात है कि हम एम्फिसाइज करें, पेशेंट को प्रिपेयर करें। जब हम प्रिपेयर करें तो पेशेंट रेडी है दवाई लेने के लिए या नहीं। अब यहाँ पे मैं थोड़ा सा अपने नेशनल प्रोग्राम वाला जो मेरा एक्सपीरियंस है वो बीच में लाना चाहूँगा, क्योंकि HIV की ट्रीटमेंट कॉस्ट अभी तो बहुत कम हो गई। जब मैंने स्टार्ट किया था ट्रीटमेंट तो 30,000 रुपये महीना थी, अब तो 2,000 रुपये महीना में मिल जाती है। बट उस 2,000 में भी आपको ये देखना चाहिए कि कितने लोग हैं जो 2,000 रुपये महीना ट्रीटमेंट अफोर्ड कर सकते हैं, बीच में CD4 करवा सकते हैं, बीच में वायरल लोड करवा सकते हैं, बीच में न्यूट्रिशन का अपना अच्छे डाइट का वो ले सकते हैं, कोई अपॉर्चुनिस्टिक इन्फेक्शन है उसका ट्रीटमेंट ले सकते हैं। जब आप अगर इंश्योर करें कि वो ये सब कर सकते हैं तो बेहतर है कि आप उनको ट्रीटमेंट स्टार्ट करें। वो नहीं कर सकते तो उनको ART सेंटर में रेफर करें। नेशनल एड्स कंट्रोल प्रोग्राम के 700 से ऊपर ART सेंटर हैं जहाँ पे 17 लाख लोगों को फ्री ट्रीटमेंट मिल रहा है। हर महीने दवाई मिलती है, सेम दवाई मिलती है, वायरल लोड टेस्ट भी होता है। तो पेशेंट की अफोर्डेबिलिटी इसलिए ज़रूरी है कि उसकी एडियरेंस अफोर्डेबिलिटी पे डिपेंड करेगी। वो शुरू में तो कहेगा डॉक्टर साहब मैं खा लूँगा, 2,000-3,000 रुपये महीना खा लूँगा, बट वो क्या काम करता है, उसके घर में कितने लोग हैं, कितने अर्निंग लोग हैं। तो ये सब चीज़ें आपको थोड़ा डिटेल में पूछनी होगी कि वो रियली अफोर्ड कर पाएगा या अभी वो बीमार है, उसकी मोटिवेशन हाई है ट्रीटमेंट लेने की। तो आप उसको स्टार्ट भी कर सकते हैं, रेफ़र भी कर सकते हैं, स्टार्ट करके गाइड भी कर सकते हैं, शुरू कर दें और उसके बाद ART में रेफ़र कर दें। सो इट इज़ वेरी इंपॉर्टेंट। और उसको ये बताना भी ज़रूरी है कि ये लाइफ लॉन्ग थेरेपी है, ड्रग के कुछ साइड इफ़ेक्ट भी हो सकते हैं। उनको ड्रग स्टोर करने में भी प्रॉब्लम आती है अगर उन्हें अपना फैमिली में स्टेटस डिस्क्लोज नहीं किया है। हस्बैंड वाइफ ने तो बताया पर घर के और लोगों को नहीं पता है, और उनको नहीं पता और ज़रूरी भी नहीं है बताना अदर देन स्पाउस, तो वो दवाई कहाँ रखेंगे। बच्चों से लोग पूछ सकते हैं रोज़ दवाई क्यों खाता है। कई बार स्कूल में बच्चे एक दूसरे से इंटरेक्ट करते हैं, तो इसलिए वेरी इंपॉर्टेंट कि आप प्रिपेयर्डनेस पे थोड़ा टाइम लगाएं पेशेंट के। हर हर विजिट पे वो 4 चीज़ें ज़रूर पूछें जो मैंने बताया: करंट का, फीवर, वेट लॉस, 4 symptom screen. Every visit you should try to rule out tuberculosis, suspect TB, and if any one of this present, refer them for TB evaluation. पेशेंट को एजुकेट करना है कि ART is not a cure, it only prolongs life, high level of adherence, drug interaction, and do not share drugs with other family members if they are not getting treatment. So what, when, how, who, these are very important. What medicine, when should be taken, how should be taken, who will administer in children and sick patient, उनको दवाई कौन देगा। कुछ रिमाइंडर्स हैं, कुछ लोग SMS रिमाइंडर लगाते हैं, वॉल में लगाते हैं, कैलेंडर में लगाते हैं, बॉटल्स आती हैं जिसमें आपको रिमाइंडर आता है, तो ये भी आप पेशेंट को बता सकते हैं। अब हमने स्टार्ट कर दिया पेशेंट को, तो पेशेंट ने ट्रीटमेंट शुरू कर दिया, तो अब हमें मॉनिटर करना है। तो क्या मॉनिटर करेंगे? हर विजिट पे बॉडी वेट देखेंगे, हाइट देखेंगे बच्चों में, ट्रीटमेंट एडीरेंस ज़रूर देखेंगे। आपने उसको एक बॉटल दी, उसमें 30 गोली हैं, उसको 28 दिन के बाद बुलाया, 4 वीक्स के बाद कितनी गोली बची हुई हैं उसमें, पिल काउंट करेंगे, उसी से पता लगेगा उसकी एडहेरेंस कैसी है। क्लिनिकल मॉनिटरिंग करेंगे, कुछ ऑपर्चुनिस्टिक इन्फेक्शन है या नहीं। फिर लैब इवेल्यूएशन करेंगे और CD4 काउंट एवरी 6 मंथ्स, और वायरल लोड करेंगे। हमने बात की थी कि हम बेसलाइन पे भी CD4 काउंट करेंगे क्योंकि हम देखना चाहते हैं कि उसको एडवांस डिजीज़ है या नहीं। फिर हम वायरल लोड करेंगे 6 महीने पे, अगर 6 महीने पे सप्रेस्ड है फिर 12वें महीने पे, और देन एवरी 12 मंथ्स। तो एक बार वायरल लोड सप्रेशन हो गया और एडियरेंस अच्छी है और कोई सिम्टम नहीं है, तो हम हर साल वायरल लोड करेंगे। और जब सप्रेस हो गया, 2 बार वायरल लोड सप्रेस आया, तो CD4 काउंट करना बंद कर देंगे। लेबोरेटरी मॉनिटरिंग में, क्योंकि वो टेनोफोविर पे है, तो हम उनका बेसिकली एवरी 6 मंथ्स रीनल फंक्शन टेस्ट करेंगे। DTG पे है तो उनका हम LFT करेंगे। सिड्यूडिन पे है तो हीमोग्लोबिन करेंगे। तो इस तरह से उनका हम इन्वेस्टिगेशन एवरी 6 मंथ्स करेंगे। नाउ यू स्टार्टेड द ट्रीटमेंट, पेशेंट इज टेकिंग ट्रीटमेंट, एंड टू टेल यू, अभी भी मेरे कुछ पेशेंट जो 15-15, 18-18 साल से फर्स्ट लाइन ट्रीटमेंट पे हैं, दे हैव नॉट फेल्ड ऑन ट्रीटमेंट। कुछ पेशेंट्स हैं जो डिस्क्लोज भी करते हैं अपना, हरी सिंह है, नरेंद्र है, ये लोग मतलब और लोगों को ये पीयर एजुकेशन भी देते हैं, मैं इतने सालों से ट्रीटमेंट पे हूँ, मेरी एडियरेंस 100% है और मैं अभी भी फर्स्ट लाइन पे चल रहा हूँ। बट कुछ लोग जो एडियरेंस नहीं होगी तो वो फेल भी करेंगे। तो जब वायरल लोड आप कर रहे हैं एवरी 6 मंथ्स और वायरल लोड मोर देन 1000 आ रहा है, तो दिस इज इंडिकेटर ऑफ ट्रीटमेंट फेलियर। अगर वायरल लोड किसी वजह से नहीं कर पा रहे हैं और CD4 काउंट आपका गिर रहा है या बढ़ नहीं रहा है, तो इट इज़ ऑल्सो इंडिकेटर ऑफ फेलियर। और कुछ भी नहीं कर रहे हैं तो कोई अपॉर्चुनिस्टिक इन्फेक्शन हुआ तो वो इंडिकेट करता है फेलियर। बट वो बहुत बाद में होगा, पहले वायरल लोड बढ़ेगा, फिर CD4 काउंट होगा, कम होगा, फिर अपॉर्चुनिस्टिक इन्फेक्शन आएगी। तो अगर आप वायरल लोड नहीं करेंगे तो देन यू विल बी मिसिंग आउट ऑन ट्रीटमेंट फेलियर, टाइमली मिसिंग आउट, एंड person will keep on accumulating drug resistance mutations. So viral load should be done every 6 months after initiation, then 12 months, and then annually. अब पेशेंट हमें वायरल लोड 1000 से ऊपर आता है तो स्ट्रेट अवे हम नहीं कहते हैं कि ट्रीटमेंट फेलियर हो गया, बिकॉज हमारे करीब 75% पेशेंट ऐसे हैं जिनका वायरल लोड 1000 से ऊपर आया, जो में रेफर होते हैं SSF को। दीपांजन विल नो दैट वी हैव ए मैकेनिज्म ऑफ एक्सपर्ट पैनल। उसमें हम देखते हैं कि लिख के आता है पेशेंट की अटेंडेंस 100% है, पेशेंट का वायरल लोड 5000 है, 10,000 है, 2 बार कर लिया उतना ही आ रहा है। तो जब हम असेस करते हैं उसको एक्सपर्ट पैनल में, तो पता लगता है नहीं, ट्रीटमेंट एडियरेंस गड़बड़ है। एडियरेंस पेशेंट को अच्छे से पूछा नहीं गया या उसने बताया नहीं। सो डिफरेंट आदमी पेशेंट से रेपो डेवलप करके एडियरेंस देखता है। फिर उसकी कुछ कुछ ड्रग इंटरेक्शन भी आ जाती है कई बार। मैं हर्बल ट्रीटमेंट ले रहा हूँ, वैद्य जी का दवाई ले रहा हूँ, दूसरी दवाई ले रहा हूँ, जो कि उसको ART सेंटर के डॉक्टर ने पूछा नहीं, उसकी वजह से उसका ट्रीटमेंट फेलियर हो गया, क्योंकि DTG की बायोअवेलेबिलिटी कम हो गई, कुछ ऑकल्ट मेलिग्नेंसीज हो गई। कुछ अपॉर्चुनिस्टिक इन्फेक्शन है, वायरल इन्फेक्शन हुआ, जब वायरल लोड करवाया था, जैसे CD4 करवाया था, वायरल फीवर हुआ, इन्फ्लुएंजा हुआ, कुछ फ्लू हुआ, उस समय वायरल लोड बढ़ जाता है। तो जब भी कोई वायर ट्रीटमेंट फेलियर का सस्पिशन हो तो ये चीज़ें ज़रूर देखें कि एडियरेंस ठीक है, ड्रग इंटरेक्शन तो नहीं है, अपॉर्चुनिस्टिक इन्फेक्शन तो नहीं है। अब ये सब भी नहीं है, फिर भी वायरल लोड हमारा 1,000 से ऊपर है, तो फिर वो उसको फेलियर कहते हैं। फिर हमें जो फर्स्ट लाइन ART है, जो हमने फर्स्ट टाइम स्टार्ट की TLD वाली, वो सेकेंड लाइन में जाएगी, और सेकेंड लाइन फेल होगा तो थर्ड लाइन में जाएगी। फर्स्ट लाइन वो ART है जो उसको स्टार्ट की गई हो, कोई भी दवाई हो, जो पहली दवाई स्टार्ट की गई वो फर्स्ट लाइन है, जो फेल होने के बाद दी गई वो सेकेंड लाइन है, वो उसके फेलियर के बाद दी गई तो वो थर्ड लाइन है। अब मैं बहुत डिटेल्स में नहीं जाऊंगा बिकॉज टाइम कंस्ट्रेंट है, इट्स ऑलमोस्ट 45 मिनट्स। सो ये स्लाइड्स भी डॉक्टर NK सिंह आप PDF करके सबको शेयर कर दीजिएगा, सो दैट दोज हु वांट दे कैन यूज देम आल्सो। तो ये सेकेंड लाइन ट्रीटमेंट है कुछ, और थर्ड लाइन ट्रीटमेंट है। बट मेरी वो है कि फर्स्ट लाइन ट्रीटमेंट में आपके यहाँ फेलियर हो तो उनको ART सेंटर में रेफर करें। सो स्टैंडर्ड ऑफ केयर जो अभी हमारा 2024 में है, इट इज़ फिक्स डोज कॉम्बिनेशन ऑफ टेनोफोविर, एमट्राइसिटामिन और लेमिवुडिन कोई एक ड्रग। प्रोग्राम में टेनोफोविर, लेमिवुडिन, डोलोटाग्राविर यूज होती है। मार्केट में कुछ लोग प्राइवेट में टेनोफोविर, एमट्राइसिटामिन, डोलोटाग्राविर यूज करते हैं, वो सेम है। So it is to be given one tablet fixed dose combination for preferred first line to all HIV infected person, whatever be their CD4 count. Monitor them viral load at 6 months after initiation, and then annually. And people with advanced disease need to be more focused. अब मैं एडवांस डिजीज के डिटेल में नहीं जाऊंगा, बट जिनका भी CD4 काउंट 200 से कम है उनको हम कहते हैं एडवांस डिजीज। इसीलिए CD4 काउंट करना जरूरी है। CD4 काउंट ट्रीटमेंट शुरू करने के लिए नहीं चाहिए, बट जिनका 200 से कम है उनको हम एडिशनल ट्रीटमेंट देते हैं। दैट इंक्लूड्स बेसिकली फ्लूकोनिजोल टू प्रिवेंट क्रिप्टोकोकल मेनिंजाइटिस, कोट्रामेक्सोजोल टू प्रिवेंट PCP, बैक्टीरियल इन्फेक्शन, एंड TB प्रिवेंटिव थेरेपी। सो जिनका भी CD4 काउंट 200 से कम है उनको एडिशनली कोट्रामेक्सोजोल, फ्लूकोनिजोल और TB रूल आउट करने के बाद TB प्रिवेंटिव थेरेपी देना है। दैट इज बेसिकली व्हाट इज द पैकेज ऑफ एडवांस HIV डिजीज। PEP रेजिमेन, नीडल स्टिक इंजरी के बाद हेल्थ केयर वर्कर को अगर कोई नीडल स्टिक इंजरी होती है तो आफ्टर इवेल्युएशन रेजिमेन नाउ इज टेनोफोविर, लेमिवुडिन, DTG। ART सेंटर में सब जगह अवेलेबल है। इवन प्राइवेट सेक्टर के लोग जा सकते हैं, किसी को भी हेल्थ केयर प्रोवाइडर को हो गया, क्योंकि बाजार में दवाई आसानी से मिलती नहीं है। सो यू कैन गेट इट फ्रॉम ART सेंटर। और ART सेंटर में भी, हॉस्पिटल में गाइडलाइन ये है कि ART सेंटर तो 4 बजे बंद हो जाता है, 5 जगह पे दवाई रखी जाएगी। OT में, लेबर रूम में, इमरजेंसी में, ART सेंटर में और ICU में 5 जगह एक एक बॉटल रखी जाएगी। तो ये जानकारी आप अपने लोगों को भी बताएं कभी नीडल स्टिक इंजरी हो, क्योंकि मेरे पास बहुत बार फ़ोन आते हैं कि दवाई नहीं थी, अगले दिन शुरू की, पता था शुरू करने पर मिली नहीं कहीं पे। तो ART सेंटर अब सब जगह हैं। ART सेंटर के अलावा 2,000 लिंक सेंटर भी हैं जहाँ पे भी ये दवाई रहती है, और लिंक सेंटर तो डिस्ट्रिक्ट हॉस्पिटल और CHC लेवल तक भी हैं। सो ये जानकारी भी आपको लोगों को देना जरूरी है, अदर देन रेजिमेन। अब लास्ट चीज है कि एक आजकल HIV सेल्फ टेस्टिंग भी आया है, किट आती है जिससे आप खुद टेस्ट कर सकते हैं, पेशेंट लोग खुद, जिनको भी हाई रिस्क अपना सस्पिशन है वो टेस्ट कर सकते हैं। और अब हम एंटी रिट्रोवायरल ड्रग्स को प्रिवेंशन के लिए भी यूज करते हैं, जिसको हम प्रेप बोलते हैं, प्री एक्सपोजर प्रोफिलैक्सिस। जो भी हाई रिस्क पे है वो टेनोफोविर, लेमिवुडिन कॉम्बिनेशन बेसिकली स्टार्ट कर सकते हैं। उसका एक पूरा रेजिमेन है, कितने दिन पहले स्टार्ट करना है, कितने दिन तक लेना है, जब तक हाई रिस्क बिहेवियर रहे। जस्ट फॉर इंफॉर्मेशन की ये भी 22 से अवेलेबल है। लास्टली, अभी तो हम 3 ड्रग यूज कर रहे हैं, बट अब कुछ कुछ स्टडीज हैं जिसमें ये आया कि 3 ड्रग स्टार्ट करने के बाद, DTG, टेनोफोविर के बाद आप 2 ड्रग पे भी कंटिन्यू कर सकते हैं, 2 ड्रग से स्टार्ट भी कर सकते हैं इंस्टेड ऑफ 3 ड्रग। ये स्टडीज हैं, जेमिनी स्टडीज, टेंगो स्टडीज। बट अभी ये गाइडलाइन नहीं है, ये सिर्फ आपकी इंफॉर्मेशन के लिए कि ये क्या आ रहा है, आने वाले 1-2 साल में क्या आ रहा है। और एटलस स्टडी हुई जिसमें कैबेटोग्राविर रेल्पाविरिन का इंजेक्शन दिया गया है, जो बेसिकली इनिशियली 4 वीक्स देते हैं, फिर देन वंस इन एवरी 3 मंथ्स देते हैं, एंड दैट कैन बी गिवन टू पीपल जिनमें टेनोफोविल एमिओटिन डोलोटाग्राविर से सप्रेशन हो गया, उनको आप इस पे मेंटेन कर सकते हैं। तो पेशेंट को एक बार 3 महीने में एक ही बार इंजेक्शन लगवाने के लिए आना पड़ेगा। बट इंजेक्शन के भी कुछ लिमिटेशन है, जिनमें टीबी वालों को नहीं दे सकते, प्रेग्नेंट वुमेन को नहीं दे सकते, ड्रग इंट्रैक्शन है, एंड दीज आर बिग वॉल्यूम इंजेक्शंस। एक नया इंजेक्शन आया है लेंकाप्रावीर, जो भी कॉन्फ्रेंस में अप्रूवल हुआ, यूएसएफडी का अप्रूवल हुआ, जो 6 महीने में एक बार दिया जाता है। बट अभी ये सब एक्सपेरिमेंटल स्टेज में है, गाइडलाइन में नहीं है। गाइडलाइन तो आपकी यही है बेसिकली, ट्रिपल ड्रग कॉम्बिनेशन to everyone monitored with viral load. Thank you. I will stop here because of time constraint and open for question answer.
Welcome, Dr. DP Singh.
Thank you,
Thank you
Dr.
so
N.
very
Dr. DP Singh.
Just
So I think-
just a bit of lack of time. Yeah, just
Yes.
examining one patient, finishing it.
No issue,
kind of
sir.
shame.
We introduced you already to our audience. First, I would like some comments from you on this talk because you corrected very well in time. So then we will switch over to Dipanjan. In the meantime, if they see any chat box question, if any, let me know.
First of all, there was very comprehensive deliberation by my friend Dr. B. Rewari. And everybody knows he is an expert on HIV/AIDS. And we have already, many times we have listened to him. He is the last word just now, in India. And but as a physician, I say that whenever this HIV came in 80s, I was just a PG student. And at that time, in our PG exam also, it came as just current affairs in 82. And you know that before that, tuberculosis with the 3-drug combination and 4-drug combination were already there. That was a huge success that this incidence of tuberculosis was reduced. But in 80s and 90s, there was surge of tuberculosis cases because of advent of HIV. And thereafter, with this HIV control programs and every other things, HIV is diminishing. But still, as a physician, anybody, any patients having cough, fever, just like the 4S he has described very well, for us, this night sweats and loss of weight. Anybody comes to this, and with the history of that, he's working in some towns, and he's a driver in the professionals. Everybody, all suspected tuberculosis cases must be screened for HIV. That is the dictum, that is the mandatory test that we should do. And even we say, because this, it is so common that any patient we can screen in our OPD, if possible, if their money affords, we should screen patients with this. That's a very, very important test that we physicians should know, because sometimes we diagnose patients, we treat tuberculosis patients, and then we find someone that, oh, we have not, HIV is not done. Even if we see the history in the different states, many states is still not 100% HIV testing is done. So that is a very bad thing. As a physician, every tuberculosis, because that tuberculosis is an indicator disease, as he has mentioned and he has rightly pointed out that. And that is one thing. In diagnosis, Dr. Rewari has already mentioned 3 steps. That is very important. That could be one. First, ELISA is positive, second and third is negative, then it will be negative, or that is equivocal, or second test will be done. That testing is also very important. So third one is that these patients of tuberculosis, especially, I say that we always say when to start. That is one of the questions, that we must start anti-tuberculosis treatment at least 10 days or 14 days when the patient has tolerated, and there is no chances of Irish syndrome. That is one of the problem whenever we treat tuberculosis. And there are other some agents also that can give rise to Irish. So Irish is again one problem that we have to see, we have to face, we must know, because that will give rise to immunoreconstitution, inflammatory syndromes, and that will give the similar pictures. Maybe that if you are treating ATT and the patient is having this, again, similar new lesions, new lymph nodes, fever is increased, joint pains and other things are increased, new pleural effusion has appeared. So we shall think that drugs are not acting, whether we are dealing with the resistant cases or not. No. So this iris, this antiviral therapy, that will increase this uh, iris problem, and we must know how to deal with this. And so any patient, anti-tuberculosis drug should be given at least 2 weeks. But if this CD4 count is high, we can start after that. Otherwise, 6 weeks is also advised. But high cases, we can start after few weeks, 2 weeks. That is important. And then in the treatment again, this anti-tuberculosis drug, he has already pointed out this dolutegravir dose should be doubled in the cases of tuberculosis because of, rifampicin is a great inducer. And before that, before this dolutegravir came into the picture, we used to replace the nevirapine, NLD. That was the first 3-drug combination for that before this TLD. This TLD has come nowadays, but another was NLD. So in that time, we used to replace this nevirapine with efavirenz. But nowadays, this is a wonderful drug has come in for the heart, this ART therapy. And so we have got just to double the dose for the treatment of this ART along with the tuberculosis. And this about the prophylactic therapy again is very, very important. If there is no active lesions of tuberculosis in cases of in this ART cases, we should and we must give the prophylactic latent tuberculosis prophylactic treatment for HIV. But just because this is a very common disease, indicated disease, very commonly associated, we always think about whenever there is HIV there, we always think about tuberculosis. Tuberculosis is there, we always want to rule out this HIV. And lastly, we will say that prevention is always best. That is still the vaccine has not come. Dr. Rivari has not mentioned about it. And I don't think that within a few years we shall have this and we shall eradicate this HIV in near future. But still we are waiting, just like tuberculosis vaccine is waiting. For HIV also, we are waiting for the right vaccines to eradicate it. But still we hope that, that Cuba perhaps is now HIV free. And there are the noises that we can have that HIV cure. Maybe that stem therapy can work and other things, some new drugs can come and we can have the cure. But one of the questions I would ask Dr. Rivari sir, that whether there is a chances of, Dr. Rivari sir, whether there is a chance of increasing this CD4 count in a patients of any drug, any way that we can increase the CD4 count, because there is progressive decline of CD4 count. Is there any way we can increase the CD4 count in a patients of ART, this HIV? Thank you very much.
Yeah, Dr. Revari.
Just 1 minute. Just give me 1 minute.
Yeah. In the meantime, I request Dr. Dipanjan. So I think Dr. DP Singh was talking about the screening of the tuberculosis patients with the HIV. So in your part of world, you are from the very beautiful city of Darjeeling. So what is the scenario in your part and how do you feel that HIV/AIDS is doing in that part of India?
Sir, good evening, and it's always a pleasure listening to Dr. Rivari, who is our teacher in the field of HIV medicine. We must admit that HIV is on the decline. So maybe because of the number of ART centers, as Dr. Rivari was pointing out, maybe because of earlier diagnosis, maybe because of better screening, but there is no doubt that HIV is on the decline. We stay in a part of the country which is known as the chicken's neck of the nation. So our North Bengal basically connects the Indian mainland to all the 7 sister states of the Northeast, meaning we have a huge highway traffic and we have a lot of truckers who travel with their trucks. So that makes this a very vulnerable area. Even then, all said and done, we are seeing an overall decline in the number of new cases that are coming up year after year. And I think this is also a reflection of the national scenario where we are now having HIV patients who have been diagnosed maybe 5 years or 10 years or even more behind from today's date, but they are doing well and they are coming to our centers for drugs. They are now having more of chronic issues. And one point I would like to add to Dr. Rewari's excellent uh, panorama of speech, that now we are seeing more of chronic consequences of HIV and ART. We are seeing less acute complications, less opportunistic infections, less cryptococcal meningitis, but we are seeing issues like ischemic heart disease, dyslipidemia. Dr. Rewari was talking about weight gain and obesity in dolutegravir, but then we also know that the other drugs are also not very metabolically uh, friendly. So there are metabolic side effects, and these are the non-infectious complications of HIV into which I guess India is gradually moving into. So there is definitely a good side that, as you asked me, the number of new diagnoses are coming down. And of course, the diagnostic strategy is same across the country, the three antigen test protocol, and all the government centers follow the same protocol across the nation. But then again, as Dr. Iwari pointed out, the private sector often uses only one kit. So my message to my friends and colleagues would be, if you have a diagnosis from a private sector, don't disown the diagnosis, don't discount the diagnosis, but have the test repeated at a government center.
Dipanjan, just I would like to ask from you that suppose I have diagnosed a case of HIV positive by three antigens positive. So should I start drug? But most of time the drugs are not available at the chemist part. So then we refer to the nearest medical college or HIV art center. So what is the scenario that a simple physician can start HIV the drug, or should I the moment we get positive he should refer to you?
Sir, number one, drugs are available if you know the brand names and maybe the company or the company's contact, or maybe a good chemist shop in your locality or city. But my personal perception would be, even what Dr. Rewari pointed out, that this is something like your cancer chemotherapy. Means we know what are the drugs for maybe acute leukemia or a Hodgkin's lymphoma, but generally we would not, me and you would not give the medicines to a patient upfront. So I would suggest let the drugs be started from the nearest ART center. Many patients would like to follow up with their private practitioners. They are more comfortable with their private practitioners. They are more confident with their family doctor. So the doctor should basically know how to monitor when things are going wrong. There is no harm if the patient goes to the ART center once a month and collects his medicine. Because again, as Dr. Rewari pointed out, शुरू में everybody will say, हाँ sir, 2,000 रुपया महीना में ठीक है सर चला लेंगे. But at the end of the day, there are added costs, testing costs, and maybe after 3 months or 6 months or 1 year, the adherence goes down. It is better to take the help of the ART center, and maybe we can all treat our opportunistic infections, side effects, smaller issues. We can all take care of them.
Yeah,
Just,
Dr.
just,
Vijay Arora, are you there?
just to add one thing, Dipanjan,
Yeah.
you rightly pointed out, but I will say yes, now with the simplification of therapy, if you have read little bit, you can always start ART. The only point is you have to see whether patient can afford it for lifelong or not. It is not very costly compared to other drugs, but generally if the person is positive, wife also will be positive, children may be positive, they will have issues of nutrition and they will have issues of money also. So you have to assess that properly. That is the most important part. It is not private or government, wherever the person gets. And as you rightly said, person can start ART at a particular center but can follow up with his own physician for his small queries, opportunistic infection monitoring. They can also, that kind of model will also be there. And also big setups, and the NACO is also open to a PPP model also, ART centers. Over.
Yeah, fine. So, Dr.
Yeah,
Vijay
very-
Arora, please ask your question. That just one
Oh.
minute. Dr. Vijay Arora is there. Yeah, welcome. So, unmute yourself. Unmute yourself, Dr. Arora. Yeah, unmute. Yeah, now.
Good evening, Dr. Rewari.
Good evening.
I have one question. Especially in tertiary care centers where patient comes, especially in patients with end-stage renal disease who are HIV positive and they are already on TLD and nobody has changed this regime. What should be the criteria? Because none of these medicine is available outside as it's in different doses. Because once in patient with end-stage renal disease or in patient with CKD stage 4, we need to remove tenofovir or we should add a Becavir. And what should be the, because these patients cannot be sent for these medicine to the government setup. So what should be the guidelines for this?
I know this is a situation you faced last week itself and two patients. I had raised this in my this thing. If your creatinine is less than 50, you really need to give separate drugs. And I said
Yeah.
separate drugs are not available in market. They are
Yeah.
actually not available in government setup also. So these have to be procured for the patient wise. That is a problem. That is a challenge to the program. So we really need to address this kind of challenge by maybe NACO can take a proactive step, and then these can be made available at selected maybe one or two chemists in the city or some places, because chemists will not keep the drugs as such because it is not profitable for him. These will expire. So I
Yeah.
agree that national program has to make some arrangement for single drugs. But if you refer them to those centers, if they are not admitted, everybody is not admitted, you refer them to ART center, they will be given these drugs. Every center gets some money.
Especially those who are repeated and they are not in a condition to go or move from that place. Or
Then ideally would be at that time you stop antiretroviral therapy.
yeah.
If you don't have simple drug, you stop therapy, stabilize the patient, refer them to a tertiary center where they can get these drugs.
Will it be a wise decision to stop ART, sir?
Hmm?
Will it be a wise decision to stop ART in such patient?
If you don't have single drugs, what will you do? What is the option? If you don't have single tenofovir, you don't have
We have
single.
lamivudine. Lamivudine is available in the market. So can we give single drug if
Yes,
at
you
all?
can give dolutegravir and lamivudine.
Yes.
Dolutegravir, no dose modification is required. Lamivudine you can modify. You can give once a day. You
Yeah.
can give DTG. I told you there are some studies like Gemini 2 study which showed that patients who are stable on TLD, they can continue to be on DTG and 3TC only. So
Okay.
they're not inferior. In such situation, you can just remove tenofovir.
Thank you very much, sir. Thank
Getting
you.
lamivudine separate also is a problem.
Yes, sir.
Panjan
I
process.
believe these are all stopgap situations. So these are not long-term recommendations. So we can always have a drug holiday or maybe use two drugs for a short duration of time.
Dr. Rewari, I must compliment the
Yeah,
HIV
but Dr.
program of
Akash,
India.
Dr. Akash, Dr. DP Singh has asked a question ki how to increase the CD4 cell count from Dr.
Dr.
Rewari.
Rewari, the main thing in the HIV is the progressive decline of CD4 count. Is there any drug or stem therapy or anything like that which will increase this CD4 count? Because that's a very important thing in
Yes.
the pathogenesis
Yes.
of HIV.
Yes, that drug is our body. If you suppress the virus replication, CD4 count will go up with proper nutrition and other thing. There is no other drug to increase CD4 count.
Sir,
Yeah,
my
Dr.
question
Akash,
to
can I
Dr.
just last question?
Uh,
Pre-exposure prophylaxis.
Yeah.
What's your comments,
But
Dr.
that is very important.
Yeah,
So
Dr.
you want
Rewari.
me to,
Pre-exposure.
pre-exposure prophylaxis is a regimen whereby we give antiretroviral drugs to prevent HIV infection in people who are at high risk. People at high risk like sex workers, MSM, drug users, transgender, or anybody at high risk. Basically, you start tenofovir lamivudine 7 days before your risk period, continue continue it throughout the risk period, and once the risk period is stopped, maybe you have stopped the risk, then you can continue for another 7 days and then stop. That is one way. Second is another pre-exposure prophylaxis, on-demand prep. On-demand prep is that you just take it 2 hours before the start of your high risk, then take another two drugs after 24 hours, and then again after 24 hours, 2+1+1. So they are different regimen. And as I said, now a 6 monthly injection lencapravir may be available in future, maybe another 1 year or so, which can be taken once in 6 months and just you can have. But ultimately, your pre-exposure prophylaxis, nothing is better than prevention and a safe sex. Use condom. Don't use.
So, yeah, exactly. So, Dr. Akash, now before you proceed for the conclusion and vote of thanks, please request for the take-home message from each of three panelists and speaker. Yeah,
Uh,
yeah. So, take-home message from Dr. Dipankar. So, you,
for
what is your
me,
take-home?
Acha,
Yeah,
Uh, Good evening.
Dipankar,
I
go ahead.
think the
yeah,
message which
Dipankar.
Dr. Rewari wanted to convey, and which I think all of us will endorse, is that number one information which should be given to the patient is HIV is no longer a fatal disease. It is a chronic manageable disease. Dr. Rewari used the words diabetes and hypertension. So it might not be curable, but it is perfectly manageable, and the person can lead a long, healthy, asymptomatic life. That is the number one message I think we should all give to our patients and to our colleagues. And number two, with proper therapy, proper antiviral therapy, proper antiretroviral regimens, the patient can be socially leading a normal life, because as we learned, that if you are undetectable, you are untransmissible. So if your viral load is undetectable, you are as good and as non-infectious as a person who is not HIV infected. I think these are two of the most important messages I would like to give from my point.
Excellent, excellent. Dr. DP Singh, your message?
My first important message is that any disease like HIV, prevention, prevention, prevention. That is the best option. Like we say, the ABC of prevention is avoid being loyal to your partners and see each condom whenever you are doing sex. Second part is that it is a treatable disease. We are treating it, may not be curable. And by that control program, we have reduced the incidence of it by 40% or so. So many people are living the normal life in this. So it is not to be a hopeless conditions now at least. So we must have get the treatment properly and continuously because it is a lifelong disease.
Yeah,
Thank
Dr.
you.
Rewari, your last message, because we are heading to 2025. Any
Yeah,
new thing will be
I
coming?
think I agree with both with Dr. DP Singh and Dr. Dipanjan. They have conveyed everything. My message to physician is that suspect HIV early, because still we see that people are coming with CD4 count which is less than 200. Almost 35% of patient in NACO program has CD4 less than 200, and many of them have been to health facility before. Either TB was not tested, there was herpes zoster which was not taken care of, there was fever, loose motion, diarrhea. They kept on giving them symptomatic treatment and they did not suspect HIV. Though the incidence has reduced over years. 10 years back, this was very common. It's not so common because physicians have also become knowledgeable over time, but still the cases are missed. So, early diagnosis, I will still say, is very important.
Yeah,
Absolutely.
yeah, absolutely. So, Dr. Akash, can you now proceed?
I also want to compliment Dr. Evari in the entire pioneers in the treatment of HIV management, that this disease, which was so dreaded, and I used to hear Dr. Maya say that every fourth Indian will have HIV, and the disease has been controlled so well. And the best part of the disease is that the government sector, the role of government sector has been exceptional, basically, because almost all of my HIV patients are taking treatment from government sector. Hardly 2 to 3 patients are coming to me for refill of their medications and management. But the government sector has played the most commendable role as far as HIV management and control of HIV in India is concerned. So they need to be complemented on every scale. And Dr. Rewari also needs a special compliment on that front. I thank him for delivering such an excellent lecture. It was a very lucid lecture, which was not at all boring. It was very, very informative and very simply delivered. And the style of delivery was so well that I think all of the audience, there must be 1,000 plus audience, have got a very good message, and they are very clear about their trajectory of HIV management. I thank Dr. DP Singh for his excellent presentation, excellent moderation, for his excellent suggestions for his excellent points that he raised to make this session extra informative. I also thank Dr. Deepanjan Bandyopadhyay for his suggestions, for his take-home message, and moderation that he did during the session, which was very enthusiastic, and we all loved it. I thank Dr. N.K. Singh, who is the person behind conducting these informative CME sessions across India. His zeal and energy is well known, and he continues to guide the entire India, the physicians, and the subspecialties of India in every area. I thank all the audience who have joined to listen to this webinar, because without their participation, our efforts will have no meaning. I thank Dr. Vijay Arora for asking a very good question, and Dr. Himalaya Jha for being there with us in this session. I thank the USV team. They are the people basically who are promoting this medical education, who are promoting these informative webinars, and who provide the online platform and the logistics for conducting all these sessions. I hand over the session to the Dr. Oshali Mohamule for final conclusion.
Yeah. Thank you. Thank you so much, Dr. Akash Singh, sir. Thank you so much, Dr. N.K. Singh and Dr. Akash Singh, for driving the CME India program so well and with so much of zeal and enthusiasm. Thank you, our expert panel, Dr. Rewari, sir, for the excellent deliberation indeed. Thank you, our other expert panelists, Professor Dr. D.P. Singh, sir, Dr. Bandyopadhyay, Dr. Arora, and Dr. Jha, for sharing your valuable insights with us. Thank you so much, everybody. Have a great night ahead.
Dr.
Thank
Singh,
you.
I have
Thank
shared
you
the
all. Thank you.
presentation with you. You can share it freely for use by anyone.
Yeah,
That is
sure,
great.
sure.
Thank you,
Please,
sir.
please, we will do a story for that. Yeah, please.
Thank you.
you.
Thank you.
Thank you.
You're on.
Thank you. Thank you. Good night to you all. Thank you very
Good
much.
night. Good night.
Good night.
Good night, sir. Good night.
Okay.
Dinner, sir. NK Singh, sir.
Sir, dinner
Where
तो
is
आप
our